It's indeed a privilege, an honor to be here with my former mentors, Dr. Dandona, and Leif Group also spoke, and Dr. Dr. DeFonja was speaking after me. So it was great to hear Dr. Dandona. Just to give a background, that I also worked with him and in hypogonadism. Before I went there in All India Institute, I worked in paper with Dr. Pankaj Shah, and we published the paper a long time back, effect on insulin sensitivity. Subsequently, I moved on to diabetes and mostly on lipid metabolism. Anyway, and it was very interesting to hear Dr. Dandona about the hypogonadism talk today. Anyway, so the title of my talk today is effect of to give you some clinical pros on use of GLP-1 agonist receptor agonist. So I'll try to keep it purely clinical, and I'll start with a case. So in a typical clinic, you'll see a patient who's a 62-year-old man with an 18-year history of long-standing history of diabetes. He's on insulin and metformin. He has also long-standing history of hypertension, hyperlipidemia, and has history of coronary artery disease. He had MI, had stent, and also has mild chronic kidney disease. Now, I asked you, doctor, my diabetes is poorly controlled. So what can I do to improve my glycemic control? And also, how can I reduce my risk of future cardiovascular event? So these are his labs. So his A1C of 8.5%, and fasting glucose corresponds to his A1C.
Sir, sorry to interrupt. Can you just put it on slideshow?
Sir, can you put on your slideshow, please?
Oh, it's not.
No, you have to convert. Yeah.
Okay.
Okay, fine. Thank you.
Okay. Were you able to see this one?
Yeah.
Okay. Okay. So yeah. So his A1C is 8.5%. His fasting is 140, and so his mild chronic kidney disease, and so his normal liver function test. So what do you do next? So which one will be the best possible agent for this patient? Would you start pre-meal aspirin insulin? I mean, you are not wrong if you can start insulin. How about glipizide? You can use glipizide if nothing else is available. However, it will put you at a risk of hypoglycemia, and there is no cardiovascular benefit. How about a DPP-4 inhibitor, sitagliptin? Again, you can use it, but it's no cardiovascular benefit and is weight neutral. So in my opinion, the best possible agent will be a GLP receptor agonist. I did not include a choice for SGLT2 inhibitor in this. You can use either the GLP-1 receptor agonist or an SGLT2 inhibitor. So this is the ADA and the ACE guidelines for treatment of type 2 diabetes. So you start with metformin and then lifestyle modification. Then subsequently, depending on if the patient has previous cardiovascular disease or has a history of chronic kidney disease, then these are the agents which are preferred. A GLP-1 receptor agonist or an SGLT2 inhibitor. So these patients particularly had chronic kidney disease and also had cardiovascular disease. So you can choose either of them, the GLP-1 or SGLT. And if the patient has heart failure, of course, the preferred agent is the SGLT2 inhibitor. So before I go into the GLP-1 receptor agonist, I just give a brief overview. I know you must have seen this slide many times. Discuss a little bit about incretins. So what are incretin effect? So not only if you give glucose through a parenterally or through intravenous route, you see insulin response. However, if you inject the same amount of glucose orally, or you ingest the same amount of glucose orally, you see a much higher insulin response. So the difference between the oral and the parenteral route of administration in the insulin response is called the incretin effect. And this effect is clearly diminished in patients with type 2 diabetes. And there are two major incretin hormones, the glucagon-like peptide 1, the GLP-1, and the other one is called GIP, or the glucose-dependent insulinotropic polypeptide. And I'll just, however, most of the therapeutic armament for type 2 diabetes is mostly GLP-1 receptor agonist. GIP has not been used for treatment of diabetes because initial studies have shown that it did not have any effect. However, recently, there's a combined GLP and GIP molecule. I'll show you a brief data on those trials. So the GLP-1 is derived from a molecule called pre-proglucagon, and depending upon the site, like intestine, the central nervous system. Pre-pro-glucagon gives rise to glucagon, GLP-1 and GLP-2. Whereas in the pancreatic alpha cells, it is converted mainly to glucagon by the PCSK2. Now, the incretin hormones, when they're released from the GI tract, they act on the beta cells and alpha cells of the pancreas. So the act on the beta cells increase insulin secretion, which is glucose dependent, and the increase in insulin secretion and the decrease in glucagon leads to increased glucose uptake by the peripheral tissue and subsequently decreased postprandial glucose levels. And also because of the decreased glucagon and increased insulin, will reduce the hepatic glucose production. And it also acts on the central nervous system. The GLP-1 has receptors on hypothalamus, decreasing appetite and satiety, increasing the satiety. And it also decreases the gastric emptying. Now, just briefly about the molecular mechanism, I don't want to go into detail, but just to remember that GLP-1, the beneficial effect of GLP-1 is that it acts or increases insulin secretion only when there is hyperglycemia. So basically, it potentiates the glucose-mediated insulin secretion. If there is no hyperglycemia, GLP-1 will not increase insulin secretion. And that is the advantage of using GLP-1 versus other insulin secretagogues like sulfonylureas, which will continue to induce insulin secretion even if the glucose levels are low. So therefore, you do not see hypoglycemia, even though it is an insulin secretagogue, it does not induce hypoglycemia. So what are the different GLP-1 receptors? The exenatide was the first one to be proved. It was derived from the Gila monster, which is found in in deserts in southwestern America. And it was noticed that these Gila monster lizards do not eat for a long time, they can stay without eating for a long time. And this molecule, exendin, was found to activate the GLP-1 receptor. And then subsequently, exenatide was developed. And subsequently, long-acting bidurian exenatide, long-acting was developed. And the next one to be approved was liraglutide and lixisenatide, dulaglutide, and albiglutide was approved, but it was withdrawn because primarily for economic reasons. Then semaglutide is another long-acting GLP-1 agonist similar to liraglutide. The newest kid on the block is the oral semaglutide, which is a GLP-1, it was approved in September 2019. So just to give you a little overview about the structure, so that's why you know which one, the mechanism of action, which is why someone is short acting, which is long acting, and which one's renally clear. So this is the top is the native GLP-1 molecule. At the second position, alanine, which this is where the DPP-4 acts and degrades the GLP-1. So that therefore the native GLP-1 has very short half-life, 2 to 3 minutes, because it's driven down by the DPP-4 enzyme. Exendin is about 50% similar to GLP-1, and it is resistant to native DPP-4. The liraglutide is about 90% similar to native GLP-1. However, it's long-acting because it attaches to the free fatty acid and which binds and attack another compound which combines to albumin. Therefore, the not renally cleared, and the duration of action is prolonged. It's about half-life to 12 hours. Semaglutide is a slightly modified version of liraglutide. Is a longer action time. It's about 1 week, half-life of 1 week. And dulaglutide is bound to immunoglobulin fragment. That's why it is again, duration of action is increased. Albiglutide is bound to albumin. So all these compounds are long-acting and there's not renally clear. That's why they can be safely used in patient renal chronic kidney disease. So there are short-acting GLP-1s and long-acting. So exenatide and lixisenatide are the 2 short-acting GLP-1, whereas albiglutide, and these are exendin 4-based, more similar to exendin, whereas the albiglutide, liraglutide, they're more GLP-1 and they're long-acting. The other long-acting are dulaglutide and semaglutide. There's another compound called IPCA. It is an implantable exenatide. It comes in a device like a matchbox. You can implant and it stays, you can keep it there for about 3 to 4 months. In fact, as a device you can use for 1 year. However, this compound is not yet approved, but it may be approved in the future. Now, these are the different devices for use of GLP-1 agonist. And as you can see, exenatide was the first one, the Byetta, and then the liraglutide and the lixisenatide. And this is the first long-acting GLP-1 agonist, the bidurian. However, initially when it came, it was not very user-friendly. And I was part of the Excel trial. I know there's a lot of dropout because it was not very user-friendly. You have to mix with a dilute the powder and reconstitute with a liquid. But subsequently it has been improved. As far as user friendliness is concerned, this the semaglutide, dulaglutide, and liraglutide are very user friendly. And most of acting ones are to be taken once a week, and the short acting ones, the exenatide twice a day, whereas lixisenatide once a day, and liraglutide is again once a day. The two other compounds, I'm not sure if that's approved in India yet or not. It's called ideglira, in which what they combine insulin degludec with liraglutide. And the advantage of this particular combination, and there's another one similar with the lixisenatide with the glargine, is that you can start at a very low dose and slowly titrate up, and thereby you can reduce the risk of adverse event. And one of the major reasons of patients drop out or discontinuous is the side effects. If you start at low dose and go slow, you can avoid the nausea and vomiting associated with the GLP-1 agonists. The GLP-1 agonists primarily act, one of the main effects is improve insulin secretion. So one of the first earliest metabolic defects that you see in patients with type 2 diabetes, loss of the first phase insulin secretion. So this study was done when I was in Sweden, the LAIF group. So we took 3 groups of patients, normal, impaired glucose tolerance, diabetics. So what happens when you give them a bolus of intravenous glucose, 0.3 gram of body weight, in normal persons like those in black dot, you can see a nice rise in insulin secretion in 2 to 4 minutes. In the impaired glucose tolerance, somewhere intermediate. However, in the diabetics, if there's completely flat response, there is no effect of intravenous glucose and insulin secretion. Now, what happens when you treat this type 2 diabetic patient with exenatide? Now, this is a study of exenatide, effect of exenatide on insulin secretion, effect of 1-year treatment of exenatide. And at baseline, these lines are superimposed. So the glucose, the diabetics do not, this is a hyperglycemic clamp. So you raise the glucose and keep it there, then you give arginine, 5 gram of arginine. So here you see that after, it's not very well appreciated, but if you magnify this image, you can see that the 1 year of treatment of exenatide completely normalized. So even in diabetics, you have a normal first phase response when you treat them, pre-treat them with exenatide. And not only the first phase insulin response, this is the second phase insulin response, as well as the response to arginine is restored. So exenatide or the GLP-1 receptors agonists are potent insulin secretagogues, and they can almost normalize the metabolic defects associated with the diabetes. Just so how clinically relevant these effects of insulin secretion are. So this is a patient who was on 2 weeks on exenatide twice a day, and 2 weeks of treatment with exenatide, I could see that almost completely normalized the postprandial rise in plasma glucose. This is continuous glucose monitoring. Now, I think you must have heard a lot about the injectable ones. Now, let me talk a little bit about the oral GLP-1 agonist. I think this one will be a game changer in the future because it's an oral agent. So how about we compare the effect of this oral semaglutide with oral empagliflozin? The 2 are most important drugs now, and the empagliflozin is one of the most widely prescribed medication now. So here they compared the effect of 25 milligram of empagliflozin with oral semaglutide, 14 milligram. And just to give you an idea of how much semaglutide you have to take when you take oral, the bioavailability of oral semaglutide is very low. So you take 14 milligram every day for 7 days, whereas which is equivalent to 1 milligram every week. So the bio ratio 1:100. So you have to take 100 milligram of oral semaglutide to have the same efficacy as 1 milligram every week of injectable semaglutide. Regardless, so when you take and the other problem with oral semaglutide is that you have to take it fasting in the first thing in the morning and with 4 ounces of water, and do not eat or drink anything for about half an hour. So here you can see over a period of 1 week, the oral semaglutide is much more potent than empagliflozin. The hemoglobin A1C reduction is 1.4% compared to about 0.9% with empagliflozin. And these are just 2 different ways of statistical analysis, just to focus on the left side. And the percentage of patients achieving A1C of less than 7% was also greater with oral semaglutide. So oral semaglutide is also comparable to injectable, or in fact better, and slightly superior to empagliflozin in terms of glycemic lowering hemoglobin A1C or glycemic effect. So how about the effect on weight? Now again, here the effect of semaglutide and empagliflozin compared on body weight. However, here the effects are completely, you can superimpose on each other. So there's exactly similar weight loss both lose about 4 kilos weight over a period of 1 year. So there is no difference in terms of weight loss effect of semaglutide or empagliflozin in weight loss. So the GLP-1 agonists, they improve insulin secretion in a glucose-dependent manner, and they also decrease glucagon secretion. They improve in animal models have been shown to increase beta cell mass. In humans, the data is not there yet. And they decrease the food intake and consistently lower A1C by 1 to 5%, 1.5%. Weight loss about between 3 to 5 kilograms of we've seen with all kind of GLP-1 agonists. How about we know that it leads to weight loss and it improves glycemic control. How about the other effects? So not only the glycemic hit, but it also has important effects on cardiovascular outcomes. So again, this is, you must have seen this several times. One of the first studies in GLP-1 agonists, although this was not designed to show a superiority, this study, the leader trial, showed that patient treated with liraglutide had a significantly reduced number of cardiac events of the 3-point MACE and the measured adverse cardiovascular event that decreased MI, stroke, and non-fatal MI. The similar result was seen with semaglutide, about 26%. The XL did not quite reach the statistical significance. However, and this is an important slide, you can see, compare the cardiovascular effects of 3 classes of drugs. One is the red one is the GLP-1 agonist, the green is the SGLT2, and the blue was the DPP-4 inhibitors. So when you practice and prescribe a drug, you can justify why you choose a particular agent. And clearly, most of the studies of GLP-1, Leader, Sustain, and Harmony, as well as Rewind, showed significant reduction in cardiovascular endpoints, except the oral semaglutide did not show any significant decrease in cardio. And SGLT2 inhibitors similarly decreased cardiovascular endpoints like MPREG and CANVAS, whereas DPP-4 inhibitors have neutral effect. There's no effect on cardiovascular outcome. However, all-cause mortality, here, the meta-analysis will show that GLP-1 receptor agonists improve mortality. Same with SGLT2 inhibitors. Again, DPP-4 inhibitors are neutral. However, the heart failure, there's clearly one agent which is superior to others is the SGLT2 inhibitors. In fact, saxagliptin has been associated with slightly increased risk of heart failure. So clearly, GLP-1 agonists have improved cardiovascular outcome. And this is particularly true for patients for secondary prevention, patients who have pre-existing heart disease. For primary prevention, the data is not clear. So there's 14% decrease in secondary prevention, whereas 6%, which is non-significant. The only trial we looked at the primary prevention is the Rewind study, which they had 70% patients without prior history of cardiovascular disease. So as a summary, so the GLP-1 agonists have a significant effect on decreasing cardiovascular outcomes. Okay, so how about the renal outcomes? We showed that this improves weight, improves glycemic control, decreased cardiovascular outcome. How about renal outcomes? So these are the studies showing effect which looked at the renal outcomes. The composite renal outcome includes the patient going to new onset macroalbuminuria, doubling of serum creatinine, or development end-stage renal disease or death. Again, so the leader and sustained is the semaglutide. Clearly showed there's a decrease in this renal composite endpoints with GLP-1 agonists. We do a meta-analysis, they showed overall the decrease about 18% decrease in renal composite outcomes, and also decreased macroalbuminuria. Now, this is, you'll be always asked in the clinic, hey, patient has a renal failure, what do you do? As I showed you the structure, the short-acting GLP-1 agonists like the exenatide and lixisenatide, they're renally cleared, so you can safely use them up to a GFR of less than 30, up to GFR 30, below 30 is not recommended to use it. Whereas liraglutide, and dulaglutide, and semaglutide, albiglutide, they are very little renally cleared, so they can be safely be used patient with very advanced kidney disease. In fact, liraglutide can go up to end-stage renal disease. There have been studies with end-stage renal disease, but it's not recommended to use. So the patient with chronic kidney disease, you can safely use liraglutide, dulaglutide, and semaglutide. And not only that you can use them, but they have been shown to have beneficial effects. Liraglutide, dulaglutide, as well as semaglutide have shown to have beneficial in terms of renal composite outcomes. So again, summarizing, the short-acting GLP-1 agonists are excreted by kidney, and you need to adjust the dose if you're using patient with advanced kidney disease. Long-acting usually do not need to adjust, and they can safely be used up to 30 to 60, and they still preserve their A1C lowering effect even patient with long advanced kidney disease. However, patient with end-stage renal disease, we do not recommend to use GLP-1 agonist. Now coming to another patient. Now this is a 27-year-old lady who has diabetes, and she was diagnosed when she was a child. How about type 1 diabetes was ruled out because she had a negative GAD antibody and has C-peptide was positive. As she has significant C-peptide, she has strong family history of type 2 diabetes. She's on insulin about 14 and 25 and a short dose of 15 units of aspartate before meals. Her A1C was 9%. Her main concern is she was obese. She does not want to gain any further weight. So she comes to a clinic because she's young. What you decide to do is increase the insulin dose. And what happens with the increased insulin dose? She keeps eating more, her A1C worsens, and the weight she gains another 50 pounds. And she switched to, for convenience, she switched to 70-30 insulin, although we do not recommend using this pre-mixed insulin, but she was switched to 70-30 twice a day. But because she was gaining weight, she was very concerned. So next, liraglutide was added. After 6 months, her A1C improved to 7.7%, and the dose of insulin significantly reduced, and she lost weight. So you can combine insulin and GLP-1 and still see a significant improvement in glycemic control as well as body weight. Now, another patient, she is a 32-year-old lady with diabetes for 5 years, metformin and A1C of 9.5%. So she comes to you for advice. So what do you do next? You can start a basal insulin. You can add another GLP-1, another DPP-4 inhibitors. However, decided to use liraglutide. You can see it just almost completely normalized her glucose levels. Now this is, we see in US very frequently patients with extreme insulin resistance. And these patients are on insulin U500, and the total insulin dose sometimes can exceed like almost 500 units per day. And this patient has an A1C of 9.4%, already on 500 units of insulin. And he was started on GLP-1 agonist, liraglutide. So even patient of very high dose insulin, you can see that there can be slight improvement in the glycemic control, and the total insulin dose almost half. So although they cannot be taken off insulin, the dose can be reduced and they can lose some body weight, and which can have long-term beneficial effects. So clearly, patient, you can combine GLP-1 agonist patient on insulin, very high dose insulin, or you can start as monotherapy. However, patient who do not have diabetes. Now this is a 50-year female with obese, has a body BMI of 35. His fasting glucose is 112. Clearly, she has impaired glucose tolerance. She has family history of diabetes. She comes to you and asks, she has already tried lifestyle modification of diet and exercise. She's not helping her. She's not able to lose weight, and her A1C is still 5.8%. So what can you do? So there are a lot of options. You can try metformin, and other agents like thiazolidine, which have been shown to prevent progression to type 2 diabetes. The problem with them is that they lead to weight gain. So there's a study, again, GLP-1 agonists have not yet been approved for using impaired glucose tolerance, but there's significant data to support the use of GLP-1 in patients before develop diabetes. They study in obese patients and treated with liraglutide. You can see that these are non-diabetic patients. They see a marked weight loss about 6 to 7 pounds, 6 to 7% of body weight. This is a study on pre-diabetics, again on liraglutide, about 5-year data, and showing about 3-year, the rate of conversion. The top line is patients who are on placebo, the bottom line is patients on liraglutide. You can show that the top line, the rate of conversion was about 6% per year, whereas those in the bottom was 2% per year. So there's an 80% reduction in conversion from pre-diabetes to diabetes. The fasting glucose decreased by about 10 milligram per deciliter. And also, however, this study had a very high dropout rate because this was a daily injection. So maybe with the patient who take an oral semaglutide, or if we try with a once a week preparation, that the patient acceptance rate will be much higher. Regardless, it clearly shows that if you treat obese patients, non-diabetic patients with GLP-1 agonist, you can prevent their development of diabetes. In fact, the liraglutide is approved in the US for treatment of obesity. It's called Saxenda. You take 3 milligrams every day. Now to compare the clinical efficacy results from clinical trials. So on the left, on the top panel, the effect on A1C, in the middle, the fasting glucose, and the bottom one is body weight. So the hemoglobin A1C on the extreme left, they compare the short-acting GLP-1 agonist. There's no difference between exenatide and lixisenatide. In the middle panel, they compare short-acting versus long-acting GLP-1 receptor agonists. And here you can see the long-acting GLP-1, particularly liraglutide, is more effective than exenatide in some terms of lowering A1C, and dulaglutide also more effective than exenatide. Then the extreme right, they compare different types of long-acting GLP-1 agonists. Here, there's not much difference except that liraglutide is slightly more effective than dulaglutide, and semaglutide was the most effective in terms of lowering A1C. Similarly, fasting glucose, it's well established that short-acting GLP-1 agonists, particularly the exenatide and lixisenatide, more effective in lowering postprandial glucose, whereas the long-acting ones are more effective in lowering fasting glucose. And this is because of more predominant effect of short-acting on gastric emptying. And there's a tachyphylaxis to the gastric emptying effect of GLP-1 with long-acting GLP-1 analogs. Regardless, you see that there is compared to all long-acting GLP-1 agonists, semaglutide appears to be most potent in lowering fasting glucose as well A1C. In terms of body weight loss, there's not much difference between short-acting and long-acting. About comparison between the long-acting GLP-1 agonists, again, the semaglutide appears to be the most potent in terms of weight loss. However, the tolerability or the adverse event, you need to keep in mind that GLP-1 receptor agonists, about 30% of them will have nausea, 15% will have some kind of vomiting, and 50% may have diarrhea. For some unknown reason, the long-acting ones are associated more with diarrhea, while the short-acting ones are associated with nausea. We don't know why. But how about these? The way to mitigate this problem that you start slow and go slow, and that way you can prevent these side effects. Yeah. So again, there's no defect in terms of nausea and short-acting and long-acting, and person with hypoglycemia, you do not see hypoglycemia if you use this agent alone or with metformin or DPP-4. However, if you combine sulfonylurea, there is still a risk of hypoglycemia, or with insulin, there may be a risk of hypoglycemia. Again, there is no difference between the different agents in terms of risk of hypoglycemia or adverse events. So now always you'll get a question from the patient that how about pancreatitis, because a lot of it praise that GLP-1 receptor agonists increase the risk of pancreatitis or pancreatic cancer. As of now, we don't know what will happen in the future, but as of now, the pooled data analysis, the latest data analysis, and then they combine all the cardiovascular trials with GLP-1 agonists, about 56,000 patients. They show do not suggest any increased risk of either pancreatitis or pancreatic cancer based on GLP-1 agonist. So as of now, there is no risk is similar whether you treat them with GLP-1 agonist or any other agent. Again, so this is just a comparison of efficacy and the adverse events of the different type of GLP-1 agonists. And clearly you can see that the long-acting ones appear to be greater, more effective in lowering hemoglobin A1C, particularly the semaglutide, and postprandial glucose. Short-acting ones are better in lowering postprandial glucose. In terms of body weight, again, as the semaglutide appears to be the most potent. And the use of the convenience or user-friendliness of the injection device, again, the newer agents like dulaglutide and semaglutide are very user-friendly and convenient to use. In terms of cardiovascular benefits, again, liraglutide, semaglutide, and dulaglutide have shown definite effect. Oral semaglutide has not shown any cardiovascular benefit yet. And in terms of adverse events, they are similar. So how do you select which patient to put on GLP-1 agonist? So it can be initiated as a monotherapy. Patient is not drug naive, not on any medication. You can start with the GLP-1 agonist, or you can combine it with metformin, thiazolidinediones, insulin, SGLT2 inhibitor. We do not recommend to combine it with DPP-4, although there have been studies. I don't think any rationale for combining a DPP-4 inhibitor with the GLP-1 agonist, because the mechanism of action is the same and you do not really see a synergistic or an additive effect. And particularly patients with prior history of cardiovascular disease, those with atherosclerotic cardiovascular disease. And in elderly, when there is a hypoglycemia, is particular concern with insulin and sulfonylurea, they are the better candidates. They are candidates for this agent. In fact, liraglutide has been approved for treatment in children in the US. So even in children, you can use GLP-1 receptor. And one particular group of patients whom this may be really beneficial, like patients who are on low dose of insulin. Those are in US, if you're a commercial truck driver, pilots, law enforcement officers, they are not allowed to be on insulin when at work. So if they're on low dose of insulin, you can conveniently discontinue insulin, switch them to GLP-1 agonist. And need to avoid using, although the data is not that, but if the patient has a history of pancreatitis, we would recommend not to start GLP-1 agonist. Patients with severe gastroparesis, again, we need to avoid using GLP-1 agonist. And the data with semaglutide has shown that there's maybe an increased risk of proliferative retinopathy. So it's not exactly linked to semaglutide per se. The theory is that when you do it, there's rapid decline in glucose levels or decrease in glycemic control that can worsen the retinopathy. As it's also been seen in type 1 diabetes when there's rapid improvement in glycemic control. So if the patient has proliferative nephropathy, the retinopathy, you need to check them before you start them, particularly the semaglutide. Now a little bit about the neo drug. This is a GLP and combined GLP and GIP agonist. Now nobody, people had given up on GIP, that it does nothing for use treatment of type 2 diabetes. Some recent studies have shown that if you lower the GLP glucose levels with GLP-1, then combine GIP, then GIP still can improve the hypotension, the insulin secretory effect. And GIP also has an effect on weight loss. So this is a combined GLP-1 GIP agonist by Eli Lilly. This is phase 2 data. You can see there's a dramatic effect on A1C control. So far, we've not seen any other agent other than insulin which can lower A1C by 2.4%. The maximum dose of this agent lowers A1C by 2.4%. And this, for comparison, this is another potent GLP-1 agonist. The red line is dulaglutide. So you can see an additional 1% decline in A1C of this agent. And here it's showing the patient achieving the A1C less than 7. Again, majority of patients on this agent achieve the A1C of less than 7. And also, and this is a very potent agent for weight loss. You see 11.3 kilogram weight loss. You rarely see in any pharmaceutical agent this degree of weight loss. And for comparison, this is dulaglutide. Again, this is combined GLP and GIP. You see about 10 kilogram weight loss, which is remarkable. But this is phase 2 data. The phase 3 data study is now undergoing, and we do not know when it will be approved. So to summarize, so GLP-1 receptor agonists improve glycemic control and reduce body weight, and the advantage, they do not produce hypoglycemia. And you can start with monotherapy or combination with multiple other agents. And the advantages are beyond glycemic control, particularly the weight loss, there's a cardiovascular benefit as well as renal benefits. So know them and use them. And the newer drugs like the one I just showed, GLP-1 GIP, has some promising results. We don't know when they'll be approved. They show remarkable weight loss and glycemic improvement, glycemic control. I think that is the last slide. Thank you.
Thank you, Dr.